going to be talking about penetrating neurotrauma, something we don't see a lot of in New York City, but I know we both saw a lot of in Miami, and I'm presuming we still do in Houston.
Well, thank you very much, Zach. Well, as I said, I'm Kitagawa. I'm the Director of Neurotrauma for UT Houston and Warner Hospital. And I was actually pretty excited when they asked me to talk on this topic because, all of us have a particular disease that we really enjoy treating, that fascinates us. And so this is one of those that in the field of neurotrauma specialists is one of those diseases that can be very easy to treat and can be nearly impossible to treat. And that's why this is sort of our, the vascular neurosurgeon's equivalent of a STA, MCA bypass type of situation when you get into really, really complicated penetrating head injury. And, penetrating head injury, much like blunt head injury, is a wide spectrum of a whole lot of different diseases. And so approaching these has to be sort of an individualized treatment as well. And along with that, I imagine for the people in this room, the experience is highly variable. From those of us that see this almost on a weekly basis to those who may not see this at all in their careers. In my discussions with the Japanese neurosurgeons, this is a completely foreign concept to most of them because it just doesn't occur very often in Japan. But when you're dealing with these problems, I felt like the best way for me to go forward with this presentation, because I could really talk forever on it, is to sort of get the nuts and bolts of how we treat these patients clinically. Why do we select a particular kind of surgery? When do we decide this is an unsalvageable injury? All those details together that contribute to how we treat these. So I have no disclosures for here. But I think the most important thing when a patient arrives for the neurosurgeon and the emergency physicians and everybody involved in their care is to decide, is this a disease that the patient can survive with a meaningful quality of life? Because if you look at the penetrating head injury population as a whole, the mortality is generally a lot higher than the blunt head injuries. And so it's really important to decide from the beginning, are we going to treat this patient with full maximal surgical and medical management, or is this a situation where anything we do is going to be trivial? Because I would make the argument, and we'll discuss that in a little bit, that every single patient with a penetrating head injury requires some sort of procedure or some sort of intervention, anywhere from a bedside washout all the way up to the maximum things. And so before we sort of institute all that, we have to decide, is this patient going to survive this with a meaningful quality of life? And so you have to combine their clinical side of it as well as the radiographical side of it to sort of make a judgment call about these patients. Now, obviously, the same things that apply to most medical diseases and the same things apply to blunt head trauma apply to penetrating head trauma. A 18-year-old is going to do a lot better than an 80-year-old. Okay, someone with no medical problems and is extremely healthy is going to do better than someone with 1,000 different medical problems and who's severely debilitated before the actual injury occurred. The post-resuscitation exam on these patients, and we emphasized that earlier on, the post-resuscitation exam is absolutely essential because a patient who is a Glasgow Coma Scale score of 3 with fixed and dilated pupils and maybe has just an abdominal respiration is going to do a lot worse than a patient who is awake and alert. The same concepts that apply to most traumatic brain injury apply the same to penetrating head injury. It's just a lot of times very difficult right there in the moment to decide on that. Along with that comes sort of a philosophical question that if a patient comes in, GCS3, fixed and dilated pupils, entrance wound on one side, exit wound on the other side, is that patient going to even get critical imaging? And that's an important thing to decide on for your particular institution. When I did my residency at Baylor, someone came in like that, absolutely did not get any imaging. The philosophy was, no matter what that imaging shows, we're not doing a surgical intervention on that patient. All patients at my particular institution at UT Houston, every single one of them gets a CT and a CT angiogram, and we'll explain that again in a little bit, because on occasion there is a rare circumstance where you see something that's going to change your management. Are you willing to go in on a patient who's a GCS of 3 with a few brainstem reflexes with a massive epidural hematoma associated with the gunshot wound to the head? Are you going in after that? If the answer could potentially be yes, then that patient needs intracranial imaging. Once you get that, that also gives you more information about whether or not this is a salvageable injury, because that's what you're trying to decide right then and there at that moment. And there are certain characteristics about that that will tell you details about the prognosis. Bihemispheric injury involving both sides of the brain. Not a hard and fast rule, but generally those patients do worse. A trajectory involving the ventricles, not specifically because of the ventricles themselves, but usually the very important structures that are surrounding those areas. The thalami, the hypothalamus, those sorts of things where any kind of recovery from that can be quite difficult. Diffuse cerebral edema, massive swelling that you see here, and obvious complete effacement of the basal cisterns in a patient who is deeply comatose with very few brainstem reflexes. In that situation, those are most likely unsalvageable. So once you make that decision, and it can be a constantly changing decision, you always have to keep that in mind, as we do have that very rare patient where you come in and you don't expect them to survive, and suddenly, a matter of minutes to an hour later, their exam is significantly improved. But once we have decided that it's not a fatal injury, I make the argument especially with my residents, that every single patient requires something to be done. Even the patient who you deem to be an unsurvivable injury, based on the imaging studies, I always tell my residents that you can't just wrap the head and just forget about it and let the patient be admitted up to the intensive care unit. I think every one of those patients, both for the family but also for the end outcome, needs a washout and a bedside closure of their penetrating wounds, followed by a wrapping of the head. Because the worst case scenario you can get is as a family who's having to deal with their family member who's dying, when you see any kind of herniation of the brain contents onto the bed. Obviously, that's an incredibly traumatic event for them to see. And on occasion, you get a patient with diffuse, tremendous cerebral edema who comes in, GCS3, fixed and dilated. You don't close up the wounds, you sort of loosely wrap the head, and they will actually herniate out of the hole. And over time, the pupils will sort of come down, they'll maybe start extending. You come from a patient who would not have survived that injury normally to the point where they decompress their intracranial contents to outside, and then you're dealing with a real problem of how do you deal with that. So even the injuries where it's an unsurvivable injury, I always tell my team, you've got to get those closed, both for the family and for the sake of the progression of that patient. When it comes to injuries that you're going to treat completely, in some circumstances, if the bullet is simply underneath the skin and maybe has some sort of overlying subarachnoid hemorrhage, washing out, either doing a localized debridement and closing up the wound is a reasonable thing at the bedside. Okay? It's not an incredibly common thing for us to happen for those patients, but simple grazed wounds can be washed and closed at the bedside, but I do believe in washing and closing up those wounds. If the patient is awake and alert, but it does penetrate into the intracranial contents and you have significant fractures, any kind of bony chips and everything like that, then the usual routine for that is a localized surgery. Meaning you go in, you extend the incision, you clean out all of those bony fragments, you make sure that the bleeding can stop. If necessary, you can put a small area of titanium mesh to cover up the bony defect, close everything up. That's the more simple of the procedures for the patients who are awake and alert. And that's how we sort of make that judgment call of, is this a patient who just needs a washout, or is this a comatose patient who needs something more? And what we've learned over the years when it comes to treatment of penetrating trauma, back in the time of Cushing, there used to be a very limited bony debridement and a very large brain debridement in an attempt to get rid of all the bony fragments, the bullet fragments, all those sorts of things. And what we've learned over the years and over the decades, and especially from the military's treatment of penetrating trauma, is in a comatose patient, generally speaking, with a concern for elevated intracranial pressure, a large bony decompression and a limited brain debridement seems to yield better results than as if you're removing a lot of brain for the sake of preserving that bony area there. And so, Rocco Armanda and some of the literature that he's published has shown that in penetrating head injury and comatose patients, the decompressive hemicraniectomy, a limited brain debridement, is the way to go for a lot of these patients. Now, obviously, whether or not to put in an intracranial pressure monitor is a very important question for everyone involved, and it's the same criteria as any sort of traumatic brain injury. If the patient is comatose, if the patient does not have an exam that is readily followable to make sure that they're doing okay, that's an indication for an intracranial pressure monitoring. But when it comes to penetrating head injury, and this is why it's so interesting to me, is that you get into these very difficult situations of how exactly do you manage it. You know, a bullet can have really almost any trajectory that you're dealing with, and so in these sort of situations, how do you address that issue surgically? And a lot of the same principles apply. So you see, this is a very common scenario of a patient with a gunshot wound to the head. A lot of times self-inflicted, where it's basically put up to the forehead, the bullet goes straight across. If this patient arrives in coma with concern for elevated intracranial pressure, the same sort of philosophy applies, and that is a large bony decompression, a limited brain debridement, placement of intracranial pressure monitoring, and get the patient out of the operating room sooner rather than later. You know, that is how we apply the same principles to the same problem. Other challenges, when the bullet goes through the mouth and up into the brain, what do you do with that trajectory? How do you manage that sort of patient? And what we found is that you manage it like any other kind of penetrating head injury. You can debride as much as you need in order to get control of the bleeding and to decompress any kind of elevated intracranial pressure. In actuality, the wounds through the mouth, generally speaking, heal quite well. At our institution, we have our ENTs go in and scope and take a look at that and follow that wound to make sure it's healing up well. But a gunshot wound through the mouth does not automatically mean the patient's going to get a tracheostomy. It doesn't automatically mean they're not going to be able to take a PO. The complicating part about that is controlling CSF leaks or potentials for other problems in that regard, and so we can address that again. The whole concept for penetrating trauma, we also have to take some of the lessons from our general surgery colleagues, in that sometimes you have to do damage control surgery in the beginning and come back later on to the definitive surgery. This is a patient I treated, gunshot wound through the eye, through the face, resulted in a fairly sizable amount of frontal contusions, also resulted in loss of the MCA and a left-sided MCA stroke. This patient is going to need multiple surgeries to repair the facial injuries, but what you need to do right then and there is make sure that she's not still bleeding, get things under control, decompress, meaning large hemicraniectomy with a limited brain debridement, and get her out of the operating room so that she can be completely resuscitated and recovered to address the issue of the facial injuries later on. So that's sort of how we manage them surgically. How do we manage them medically? And when it comes to that, we treat them like other traumatic brain injury patients. You know, serial neurological exams, imaging if necessary. The specific part of penetrating head injury is complication avoidance. What are the things that are going to come from penetrating head injury that you need to address along the way that are sort of unique to that? And obviously the one that we all worry about is infections. And this is one situation where our field of neurotrauma has not really come up with a full consensus about how to manage this. And as recently as 3 months ago, we did a poll around the room. What do you do with a gunshot wound to the head who's had a surgical intervention? How long do you keep them on antibiotics? Perioperative, 24 hours, 3 to 4 days, 1 week, 2 weeks. So if you look all around the table to those that we would consider to be, you know, our experts in the field, highly variable. You know, Ross Bullock in Miami, 1 week of IV antibiotics. And the antibiotics, the choice is dependent on how contaminated the wound is. David Okonkwo in Pittsburgh, perioperative antibiotics. Rocco Armando with the military, perioperative antibiotics. Houston, when I came in, we do a full week of IV antibiotics. And my personal philosophy and approach to this is, I think we need to tailor this based on the patient's needs. Every patient is a little bit different, and if it is a non-contaminated wound that has a good debridement, a good washout, perioperative antibiotics, absolutely. If it's a very dirty wound, open exposed wound that's generally contaminated, I think a longer course of IV antibiotics is reasonable. But that's one question we have not answered as of yet. Seizures is another issue. You know, in the blunt head injury population, I think most of us follow the guidelines of 1 week of anti-epileptic medications, and if they don't have a seizure during that time, you stop it. Is it the same thing for penetrating head injury? If you look at this population, the incidence of seizures can be up to 50%, sometimes in some studies even higher, and some of those seizures can happen years afterwards. So in some institutions, they keep anti-seizure medications going for a year. Others, it's just the simple 7 days. There's not a really great guideline to tell us exactly what to do in that situation either. And that also, I think, is very patient-centered as well. You know, I generally speaking keep my patients on anti-epileptics for somewhere between 7 days and a month, or depending on the extent of their injury and my concern and clinical concern for whether or not they're having seizures. So infections, seizures, obviously a concern. Pseudoaneurysms is something that you don't think about until you have them blow up in your face. And that is the reason why every patient who comes in with a head injury, with a penetrating head injury, we've worked it out to where the ER will automatically do a CT and CT angiogram at the same time. Because the worst thing you can do is get into a surgery and be in a situation where you don't know what's happening down below. In the patient that we just showed who has the gunshot wound to the face, she actually had what you see here. This is her CT angiogram at the time of her arrival. She had already formed a very large pseudoaneurysm in that area that would actually rupture at a later time. Basically what we do in these situations, what we did in her situation is we do a CT-CTA at the time of arrival. If we're taking the patient to surgery and they have a pseudoaneurysm such as this, we have a hybrid suite where they go and they get an endovascular treatment of their aneurysm, which she did, followed by a decompressive hemicraniectomy at the same time on the same table as soon as the angiogram is done. And that way we can maximize the potential to make this as safe an operation as possible. In her case, she actually, even though she was treated, re-ruptured her aneurysm less than 7 days out for her injury. And that was also an important lesson for me to learn, is that when it comes to these, it doesn't necessarily automatically mean they're secured, and it also does not mean that she can't form a new pseudoaneurysm on another part of the vessel because of the blast injury. This one right here is another patient who actually we did a CTA upon their arrival, a CTA at 1 week, and then he blew his pseudoaneurysm at 3 weeks out. And this is the challenging part about these, and that's why we always need sort of the input of our cerebrovascular colleagues about how high risk this particular patient is. Now, our particular protocol now, after learning through all these situations, is CTA upon arrival, CTA at a week. Now, if the bony fragments make it so you can't see the vasculature, then we actually do a conventional angiogram at a week. And then depending on the degree of clinical suspicion for the possibility of it, we could have another screening at a later time, like at 4 to 6 weeks out. These are important lessons to learn along the way. When it comes to actually removing the bullet at the time of surgery, generally speaking, unless it's immediately accessible, we leave it in place, because digging around after that bullet can cause more complications than it's worth. The reasons to actually take out a bullet usually happen later on. You know, if there is an infection in that vicinity, a cerebral abscess, or if the bullet starts to migrate, which can happen. It's fairly rare, but it can happen to where the bullet can actually migrate and can cause new neurological deficits. The other types of penetrating head injuries can represent quite a bit of a challenge. You know, things like hammer to the head. This is a patient that we treated that was an extreme challenge, both for medical and also for social reasons. You know, what do you do with the patient with the nail to the head? What do you do with these other sorts of situations? And it adds an element of complexity in, number one, how do you get the thing out? Is this like a bullet you can't leave in place? Number two, how do you prep it in? How do you get this thing sterilized to the point where you can actually remove it? And how do you remove it in such a way where you're prepared to deal with the consequences of new hemorrhages as a result of going in? So that's sort of that requires the planning. In this case, we basically had to more or less prep the entire hammer as we were going in very gently, and then removing the bone from around where it is without dislodging it, and then basically be prepared to remove it at the instant where you're prepared to have hemostasis as well. So these are quite challenging problems, but this is the whole reason why we get interested and excited about these very difficult and challenging cases. Thank you.